Metabolic response to trauma Part 1 written by Jonathan Aja MD. Definition. Metabolic response to trauma is the accompanying physio-biochemical changes that occur in the human body, systems, tissues and cells whenever there is a significant exchange of energy between the body and the external environment. It could be in a controlled situation, for example, in the operating theater, or an uncontrolled environment, for example, during a road traffic accident. In 1930, Sir David Q. Berthson conceptualized the above response using the sea tide waves. He described them as ebb and flow phases. The ebb phase is when the sea tide is reclining, and the flow phase is when the tide is flowing, if you like, raging. The ebb phase, all the early or ebb phase tries to do is to ebb, in other words, recline the tide of the local and systemic cascade of responses triggered by the injury. The ebb phase begins at the time of injury and lasts approximately 24 to 48 hours. It may be attenuated by proper resuscitation but not completely abolished. The ebb phase is characterized by physiologic and metabolic responses easily remembered by the simple acronym HART. Hypovolemia, hypothermia, acidosis of the lactic type, reduced cardiac output and decreased basal metabolic rate. The predominant hormones regulating the ebb phase are easily remembered by the acronym CAC, catecholamines, aldosterone and cortisol, especially following the renin-angiotensin system activation. The main physiological role of the ebb phase is to conserve both circulating volume and energy stores for the recovery and repair of cells and tissues damaged during trauma. The next phase is the flow phase. Following resuscitation, the ebb phase evolves into a hypermetabolic flow phase corresponding to systemic inflammatory response syndrome. In addition to ushering in the flow phase, this also heralds a period of significant inflammatory changes. It involves what is easily remembered by the triple R response, or recovery of tissue, repair of tissue and replacement of tissue, through mobilization of body energy stores. Furthermore, it is characterized by the following physio-biochemical changes easily recalled by the acronym TIRLI. The responses are tissue edema, increased metabolic rate, raised body temperature, increased oxygen consumption, leukocytosis and increased gluconeogenesis. The flow phase may be subdivided into an initial catabolic phase, lasting approximately 3 to 10 days, followed by the anabolic phase that may last for weeks if extensive recovery and repair are required following a serious injury. Now that we have established that metabolic response to trauma can occur in a controlled environment, for example, during a surgical operation or in an uncontrolled situation, for instance, during a knife stabbing or burns, in the following injury, the body response is mediated in what can be easily recalled by the TEN or TEN response. This response translates to the acute inflammatory response, endothelial cell activation and neuroendocrine response. These generate an acute inflammatory response concurrently with a vascular endothelial response activating the clotting cascade. The neuroendocrine system is also activated through the pain pathway, and in addition the hypothalamic pituitary adrenal axis responds to stress, leading to increased, decreased or no change in a number of key stress and non-stress hormones. Acute inflammatory response. Physical damage to tissues results in local activation of cells such as macrophages that release a variety of cytokines. Systemic inflammatory response syndrome, SIRS, following major injury is driven initially by pro-inflammatory cytokines, including interleukins 1, 6 and 8 and tumor necrosis factor alpha. Interleukin 1 mediates fever, T-cell, and macrophage activation. Interleukin 6 mediates growth, differentiation of lymphocytes and the acute phase response. Interleukin 8 is chemotactic for neutrophils and T cells, and tumor necrosis factor alpha is pro-inflammatory, meaning it leads to release of leukocytes by the bone marrow in addition to activation of leukocytes and endothelial cells. If prolonged or excessive, the above may evolve into a counter-inflammatory response syndrome, CARS, characterized by suppressed immunity and diminished resistance to infection mediated mainly by interleukin 10 that affects the immune system. The endothelium and blood vessels response is usually a consequence of the acute inflammatory response triggering the coagulation cascade through a myriad of changes. Most of the inflammatory cytokines are procoagulants. Therefore, there is some degree of hypercoagulability in trauma patients. Once coupled with endothelium injury, which is commonplace in trauma, the Virchow's triad is easily completed, as most injured individuals tend to be static or move less generally. Sometimes these factors can lead to widespread activation of the coagulation cascade, i.e. disseminated intravascular coagulopathy. The classical neuroendocrine pathways of the stress response consist of afferent nociceptive neurons, spinal cord, thalamus, hypothalamus, and pituitary. The next key response is the hormonal fluctuations that occur. In my opinion, this is best remembered by classifying the hormonal fluctuation into hormones that remain the same, hormones that increase, hormones that decrease. Hormones that remain unchanged can be remembered with the mnemonic follow learning traditions, which translates to follicle-stimulating hormone, luteinizing hormone and thyroid-stimulating hormone. Hormones that increase can be recalled by the acronym GAPA, meaning growth hormone, adrenocorticotropic hormone, prolactin and antidiuretic hormone, in addition to the acronym ACA, which translates to adrenaline, cortisol, and aldosterone, supplemented by the acronym RAG, which reads as renin, angiotensin, and glucagon. Hormones that decrease can be recalled using the acronym TOT, which includes thyroid hormones, estrogen and testosterone. We will conclude part 1 of the podcast and complete the rest in part 2. Please do not forget to subscribe, like, follow and share the YouTube channel Large Academy, where we make medical education interesting through innovative teaching.